welcome back to Balanced Health. Colorectal cancer is the third deadliest cancer in the U.S., but with proper screening, you can significantly reduce your risks. Today, we're discussing what screening each of us can take with our special guest, Dr. Dan O'Reilly. And of course, we've talked about the colonoscopy, which is the most reliable test, and everybody should have one. I wanted to just briefly mention some of the treatments for colorectal cancer. Dr. O'Reilly, before we run out of time, because that's important, and how do you treat it? If you find polyps that are cancerous, then what happens?
Well, the most definitive treatment for colon cancer is surgical removal. We do that endoscopically when we remove polyps that have cancer in them. If we can completely excise a cancerous polyp and it's in very early stages, we may be done. If it's more advanced, then you need surgery, and the majority of patients are cured with surgery alone. And again, it depends on the stage of the cancer, and colon cancer is staged depending on how far it grows into the wall of the colon. The more superficial, the earlier the stage, the better the prognosis. The deeper it penetrates into the wall or through the wall, the higher the stage, the worse the prognosis. And you can actually graph that out. It's pretty straight line in terms of the prognosis. When you get beyond the early stages, stage 1 or 2, we then begin to talk about adjuvant therapies, things that we can do to reduce the risk further. For example, if you have a 70% rate of being cured from a colon cancer just by surgery alone, you might say that's pretty good. But if we give you adjuvant chemotherapy, a standard regimen like 5-fluorouracil and leucovorin, which are the drugs that have been used for ages, we might improve that to 75 or 80% cure rate. Now, the patient might say, well, gee, that's only a 5 or 10% improvement over what I had with surgery. I don't think I'll go through 6 months of therapy. But turn it around. Your chances of having a recurrence are about 30% if you're 70% cured. If you get a 10% improvement in that, down to 20%, that's a 33% improvement in survival.
And that's significant.
That's
That
significant.
is very significant.
So there are patients who have the stage 2B, 3 colon cancer who do benefit from getting additional chemotherapy treatments. In addition, rectal cancer is unique in that it responds to radiation treatment as well. So rectal cancers, we may add radiation treatment in addition to chemotherapy, and in the current state of things, we're often treating rectal cancers with radiation and chemo before we operate. We'll make the diagnosis endoscopically, we'll give them the course of treatment to try and downstage the cancer, actually take it from a stage 3 to a 2, for example, and then do the surgical resection in the hope that maybe we can spare that patient a lifetime colostomy, maybe improve their overall prognosis at the time of surgery.
Now, colon cancer, is it caused from different types of tumors? I mean, are some more aggressive than others, or is it always the same? You know, you hear like non-small cell carcinoma and stuff like that. Is colon cancers differentiated like that?
Almost all colon cancers are adenocarcinomas.
Okay.
Adeno means they arise from glandular tissue, and the colon is loaded with glands. It's an organ that secretes a lot of mucus and things as part of the digestive process and the lubricating process. You will get rare tumors in the colon, lymphomas, sarcomas, but they're a tiny minority. So the majority of patients who have colon cancer have the run-of-the-mill adenocarcinomas, different from lung cancer. We have small cell, large cell adenocarcinomas. We rarely see those in the colon.
How about the staging and the prognosis? I mean, you know, you look in the Merck's manual, whatever, it says if you get it in stage 1, 75%. Can you just talk about that? Because hopefully it'll give us some preventive incentive for
and that's a good question, Joe. That's the reason why we screen. If we can find a polyp that has a little bit of cancer in the surface and we remove it endoscopically, that's stage 1, you're cured. You need nothing more than a colonoscopy and then a follow-up. And we know that the incidence of colon cancer goes up with age. So if we get people into the screening program, you know, between that age 40 and 50, when the incidence is starting to go like this, we'll make a big difference in the overall incidence of colon cancer. If we wait till they've got symptoms or they've got an advanced stage 3 cancer, the prognosis drops way down, and then all we can do is salvage. And if it's metastasized to the liver, we're not really talking about cure, except in rare instances when we get a single metastasis and we may be able to remove that. Most of those patients, we're trying to buy them time with treatment. So you want to find it before it's gotten to the advanced stages.
So follow the protocol.
Yeah.
Yeah, that's important. Well, we were going to mention a couple of other colon conditions because some of them actually are linked to colon cancer. What are those?
Well, genetic conditions. Familial polyposis, for example, is a condition where patients form literally hundreds of polyps in the lining of the colon. Every one of those patients will develop colon cancer if their colons are left in place long enough. We actually begin screening those patients at age 12. It's a autosomal dominant inherited disorder. It means all the members of a family will get it. Lynch syndrome, it's also called non-polyposis colorectal cancer syndrome, is associated not only with colon cancer, but with endometrial cancer, kidney cancers, pancreas cancer. So when we identify a patient with Lynch syndrome, we start testing all the family members to see who has it, and we put them into a tighter screening program. And then we talked earlier about inflammatory bowel disease. Not genetic links, but Crohn's disease and ulcerative colitis increase your lifetime risk for colon cancer. And those patients, when they've had the disease for at least 10 years, we begin to screen them on a regular basis as well.
But we don't want to scare people. Because they have IBS doesn't mean these things mimic each other. Is that right?
Well, irritable bowel syndrome. We have to be careful with our terms. IBS is irritable bowel syndrome. That's the common colitis that people get all the time, you know, my bowel problem. Inflammatory bowel disease, IBD, is a different disease.
I'm glad you differentiated that.
Yeah, that's an inflammatory disease of the colon. Those patients do have an increased risk of cancer. Irritable bowel patients don't. The problem with irritable bowel is that those patients may have symptoms, lifelong symptoms, and you don't know when that symptom represents colon cancer or it's simply their irritable bowel. So they need to fall into the same screening program as healthy adults, sometimes a little earlier, because you can't tell whether the symptoms represent of developing cancer or simply their irritable bowel syndrome.
So would one of the possible symptoms then be frequent diarrhea, those kinds of things that would be similar to irritable bowel? Or
Sure, irritable bowel, the textbook description is alternating constipation diarrhea. The patient has cramps and pains and they're constipated for 3-4 days, and they get explosive diarrhea, get relief for a couple days, maybe constipated again, and then starts all over. That's sort of the textbook. But irritable bowel, because we call it a syndrome, is not really a disease, and so it covers the spectrum of diarrhea, constipation, cramping, pain, bloating, gas, belching. It's really a kind of a leftover diagnosis when we've ruled out underlying disease processes. But it's a very common disorder. And because those patients have digestive symptoms, they need to be watched even more closely, because you don't know when those symptoms represent something other than just their irritable bowel.
How about like Crohn's and celiac and some of these things where you have this intestinal compromise for extended periods of time? Are they increased risk of colon cancer?
Well, Crohn's patients, much like ulcerative colitis patients, inflammatory bowel disease, IBD, do have an increased risk of colon cancer if the disease is in their colon, if they've had it for an extended period of time, usually greater than 10 years. Patients with celiac disease may have an increased risk for something called microscopic colitis, but probably not colon cancer per se, although they may have an increased risk for intestinal lymphomas, which is another topic.
Well, we have a minute left. What's the most important thing you'd want to leave with our audience today?
Well, I think everybody needs to be checked. You know, we're all under the same spotlight here. We all need to know that we have a lifetime risk of colon cancer, some higher than others. We don't know where that average risk falls out. You know, some people never get it. But if 5 to 6% of us are going to get colon cancer, it sure makes sense for everybody to be screened at some point. If you get a negative screening test at 50, you're probably good for 10 years or longer. Some people are now arguing if you get a one-time negative screening test, you may be good for life. I think you ought to probably follow up at least every 10 years.
It's worth a half a day of your time, isn't it?
It sure is. And it's obviously a very slow-growing cancer, but it's deadly. So
Yes.
you do need to get those tests. Well, remember,
thank
thank you so much, Dr. Dan. It's
pleasure.
been very helpful. And if you'd like to order a copy of this show or last week's show, just give us a call. And coming up, a healthy and refreshing pineapple celery drink. Stay tuned. We'll be right back.